Recording in progress.
Dear friends and colleagues, this is the first online seminar of the... Γιατί παιδιά έχει διπλή? Of the Committee on Prevention and Health Promotion of the European Association of Professors Emeriti, which was formed 5 years ago. This committee has many purposes, which can be, in the next slide, please. The next slide, please. It is common life that it is common knowledge that a healthy life is a requisite for every human achievement. Professors Emeriti have a great responsibility towards helping all individuals to achieve a longer and healthier life, thus preserving and promulgating their capital of knowledge and of age. We are lucky to have with us many co-participating institutions, and we hope that in the future they will increase. The program tonight seems very interesting. May I have the next slide, please, for the program. The first speaker will be the president of the European Association of Professors Emeriti, Professor Natale Gaspare De Santo, from the University of Campania, Naples, who will give the welcome. Professor De Santo, we are awaiting for your welcome.
Good evening to everybody. Thank you very much, Professor Kokkinos, for inviting me to join the first event of the new committee of the European Association of Professors Emeriti. Sir Professor Magdi Yacoub may remember that in the middle of the 80s of the last century, the walls of the underground in London were covered by posters in bright colors over a black background with a message: "Don't die of ignorance." It was the Margaret Thatcher's campaign against AIDS. Health protection now is a costly procedure, since the present model is based on cures, a pill for every disease, the dream of Paul Ehrlich. Health systems worldwide tend to collapse because of their increasing costs. Thus, they have been put in the hands of managers who have leveled resources and expenditures by reducing the quantity and the quality of services granted. This was the end effect of the advent of the managed care, a byproduct of the uprush of the economy in all aspects of human life. This has generated healthcare systems that are unjust. According to Sir Michael Marmot, now director of the Institute for Health Equity at the University College of London, along the Washington subway, departing from the poor quarters in southeast of the city where blacks live, the rich to the rich county Montgomery, where rich people live, for every mile, the length of life of the inhabitants increases of 18 months, for a total at the extremities of underground of about 20 years of difference in life expectancy. In other words, according to the quarter whereas when one lives, and according to the economic and the cultural resource, life expectancy varies from 58 years to 73 to 70 out. Now, 20% says of the patients use 80% of the resources. In the long run, there is only one possible way, both for the society and the single individual. We need to act on causes of disease, promoting a policy of prevention. Nowadays, we invest in prevention only 2% of the healthcare budget. As pointed out by Leroy Wood, medicine is changing from the traditional reactive mode in which doctors wait for people to get sick to a mode that is far more preventive and rational. It is called the P4 medicine, predictive, personalized, preventive, and participatory. The focus of medicine being placed on the individual patient. The focus on healthcare thus shifts from dealing with disease to maintaining wellness. Research also changes or must change, and the medical education will also need to be transformed. We need to promote clinical research. Without basic research, everything collapses, including economy. But without clinical research, very little trickles down on patients and on their expectation for cures and the quality of life. Today, a few discoveries in basic biomedical research get turned into treatments and cures. Scientists call the gulf between a biomedical discovery and the development of a drug the valley of death. I like to invite the students to consider that there is another impending problem, the new medical industrial complex that might be more efficient than its non-profit competitors, but it creates overuse of services and cream skimming, and may also exercise undue influence on national health policy, as discussed for nearly 30 years by Arnold S. Relman, the editor-in-chief of the New England Journal of Medicine. The monster is like the mythical Hydra, with many heads, and we shall abate this Hydra, said recently the president of American College of Physicians of USA. I can't touch the pertinent theory of epidemiological transition of Abdel Omeran. The theory has been adjourned and finally poverty has been taken into consideration along with incomes. It has been shown that rich and educated people are not at variance from poor, non-educated people in adopting intemperate lifestyles, causing uncommunicable diseases associated with morbidity and mortality. However, rich, educated people, when made aware of the risk connected with those diseases, accept to modify their lifestyles, whereas poor, not educated people will not. Thus, the latter group will experience morbidity and mortality of the disease at the time rich, well-educated people have achieved protection. I thank again for the invitation and conclude. We still die of ignorance. Clinical research and prevention are fundamental elements of sustainable healthcare systems based on patients' needs. Science will rescue us, but as Luc Montagnier says, mieux que guérir, prevenir. Prevention is better than cure. We have to do new things and in different ways, says the mythical Fiona Godley, the retiring editor-in-chief of a British medical journal. Thank you again for listening to me.
Very much, Professor De Santo, for this inspiring salutation, this inspiring greeting. Please, you will see that you can send by writing questions during our conference. We shall try to answer some of them tonight. The rest will receive a written response. And now we give the stand to Professor Sir Magdi Yacoub, who will also salute the audience on behalf of our committee. Professor Sir Magdi Yacoub, apart from being the foremost surgeon of our times, has many philosophical but also practical thoughts of how to manage questions of health and life expectancy and progress in our era. Sir Magdi.
Good evening. Thank you for organizing this excellent meeting. It is my distinct privilege to welcome everybody following Professor De Santos' talk to this meeting. It is an inaugural meeting, and I hope everybody, including us, of course, to learn how to advance healthcare, like what Professor Kokinos have just said, that this health promotion is a very important and wide spectrum, and it takes us from prevention to advanced surgery. So it is a continuum, and both of them depend on each other, and hence the choice of my talk, the title of my talk, which is to do with heart transplantation. Next slide, please. Thank you.
Thank you, sir.
Thank you. I have chosen to talk about transplantation rather than prevention because I think the subject is a continuum, how to promote health. And they're not only a continuum, but actually they depend on each other. And my title is, as you see, the clinical application of research in organ transplantation. It's ranging from transplantation to regeneration. And I will explain why this is important for health promotion. Next slide, please. Can you move? Yes. Stop. It's not on the screen.
No, it isn't. What's happening?
Can you see the slides? You can work on this, forget about the big one.
The slides are on.
The slide is on. Can you see the first slide or the second? Chronology or
Yes.
not?
Yes.
Okay, so forget this one. So in this short talk, I will talk about heart failure pandemic, the expanding role of left ventricular assist devices, potential for regeneration and what is regeneration, and then I'll explore avenues to deal with this major problem in a variety of ways. Next. So the Global Burden of Disease series published in the Lancet show quite clearly that non-communicable diseases, including heart, cardiovascular, is on the increase. This is obviously before the recent pandemic of communicable disease in the form of COVID-19. But I show this slide to show how heart failure and cardiovascular disease is on the rise. And we have to do something about that in our association, but also worldwide. So what do we do about it? Next slide. In its severe form, because we still don't know exactly, we have several avenues to produce which cause heart failure, but eventually it is progressive, and once it is very severe, the only viable modality of treatment is transplantation in these very severely sick patients with heart failure. However, there is severe shortage of donor organs worldwide. Some countries don't have even one, rather than others have 30 per million, etc. So by necessity, left ventricular assist devices, which are pumps, artificial pumps, are put in to salvage these patients. They do, but they have a fair amount of complications. The most exciting aspect of left ventricular assist devices is when they are used as a bridge to recovery. And that is what regeneration is all about. So you can say that regeneration is born or stimulated or inspired by transplantation. That illustrates my point about the continuum of promoting health. Next. And this is just a slide to show how the number of left ventricular assist devices are increasing. But it gives an unprecedented opportunity for what I call bridge to recovery, rather than always go to transplantation if we can. Recovery is regeneration. Now, if we try and do that, we have to understand the pathobiology. It has been shown that bridge to recovery reverses almost for the first time both the structural and functional changes in heart failure. That immediately begs the question, next one please, what is regeneration? It is defined in the left ventricular assist devices sense as essential to have explantation. Because many people say, oh, the heart has improved while I was performing transplantation 3 months later. That is not total regeneration. And if you look around the world, you look at some centers have 0%, and others up to 40%. That's a huge spectrum. And therefore it is center dependent. How hard you try to induce regeneration by a variety of strategies. Next slide, please. And the important thing that immediately show that we have to understand the mechanism, as I said earlier, of regeneration. It turns out that it is either this can be done by increasing the number of contractile cells in the heart, the so-called cardiomyocytes, or improve, and that can be done by either injecting cells or by stimulating cells to divide. And there are strategies already evolving in that direction in both fields. The second is trying desperately to improve the existing myocardium. And the myocardium is not just contractile heart cells, it has many other types of cells, which time will not allow me to talk about. And the net result of regeneration is reversal of heart failure, which up till now has been called a syndrome. When you talk about syndrome, you mean that you do not know the exact pathobiology. So this is not a good thing. We need to actually know the basic mechanisms and the causes. It turns out that the causes, next slide please, are not one. So there are two ways of looking at it, reductionist versus an expansive approaches. And I saw Paul Ehrlich and Robert Koch, where they found that you go, one cause causes the disease. Not so, we have heart failure. Next slide, please. It has so many causes, and they meet in a complex fashion, and there is no way you can treat 6,000 causes, as is shown in this slide, this little boy fighting a swarm of insects with a broom. He has no chance whatsoever to get to the point. Instead, now we have many strategies to handle multiple data. Next, please. And one of them also is complex network. And the complex network, more about that in a minute, consists of collection nodes which actually collect and interconnect the other nodes, and some are decision nodes. And the whole secret, as in this article published sometime in circulation, is to define or find out which is a decision node and which is a collecting information node. Next slide, please. So it has to be radical, and it should involve what is called a paradigm shift. And paradigm shift has been defined by Kuhn, and this is the cycle of paradigm shift. We need to think outside the box, if you like. Next slide, please. So in our center, we have a recovery program using left ventricular assist devices with many nodes, and this is just shows how they interact together. Next slide, please. I will just touch, I can't be expansive, but I will touch on some new, and that is what discovery is all about, novel pathways which needs to be explored, and it is very exciting indeed. The first is protein unfolding, which has been called Alzheimer disease of the heart. So it's not only the brain which gets Alzheimer disease, but this is borrowed, that protein unfolding, if it cannot be corrected, it results in deposition of fibers and Alzheimer disease type. And there are also part of the cell, any cell, particularly in this case, the cardiac myocyte, they have various mechanical dysfunctions. And how is that? You have to be studied. Another one is the connexin 43, a molecule which is in the heart muscle between two parts of the myocardial cell, is proving to be an incredible source of excitement, as I will show you. I'm just enumerating the pathways. ECM is the extracellular matrix, which is it's like the cement between the cells. And good heavens, it is full of messages and crosstalk from this cement around the cells and the cells themselves. And that is a focus for research. So it is clinical and basic science. Here, this continuum is essential to understand. We cannot just, it's not a monogenic disease. It's not clinical and hospital treatment versus prevention. They are a continuum. Next, please. I will not go, I talked about the protein unfolding and the Alzheimer disease of the heart, and that shows that proteins during metabolism, they become unfolded, and unless there is a mechanism for unfolding them, they form deposits either on the brain, causing Alzheimer disease of the heart, of the brain, or in the heart, it causes heart failure. And this is proving to be a very interesting line of research, because for the young people who want to pursue something really exciting, there are mechanisms for unfolding the wrongly fold proteins, and these can be stimulated and get rid of the problem, Alzheimer's disease of the heart. Next slide, please. They talked about mitochondria, and mitochondria are part of inside every cell, and they play a major role in what we call metabolomics. And they prove to be, in our case, for example, on the right side, there are many molecules which go up or down. We're trying, and it interacts with the DNA of the nucleus. This is another avenue which is being explored by our group and others, of course. We're not the only people in the field. Next, please. And for example, you can look for mitochondrial DNA in the blood. Next, please. And that's when it leaks from the heart muscle cells. Next, please. This is what I showed you about connection 443. You see on the right-hand side, it's a normal heart muscle, and on the left, the boundary between cells for connecting one myocardial fiber have disappeared. Actually, they have not disappeared. They are dispersed in the cell. All these mechanisms actually produce heart failure. So the one on the right is from somebody with severe heart failure from our center. Understanding all that is paramount if we are to conquer the pandemic of heart failure. Next, please. And these are biomarkers which, again, are essential to understand the pathobiology, because you can see how they correlate or do not correlate with recovery and regeneration. Next slide, please. I mentioned earlier complex networks, and there are many types of complex networks, from societal to electrical to intracellular to disease. And they really has come, the mechanisms and the science of complex networks have come to the rescue in many areas where you have big data and start to apply these rules of complex network. Next, please. And the next idea is artificial intelligence, which is just an extension of complex network. Next slide, please. In conclusion, on the bridge to recovery or regeneration, which is a product of cardiac transplantation through being stimulated and researched into, requires a paradigm shift. We have to think outside the box, which enable the promise, only a promise, but it's already started to solve the riddle of cardiac regeneration and reversing the pandemic of heart failure. I can show you very sorry figures from around the world. Next, please. The data presented here is the product of several young people here in Aswan Heart Center, who are the research group on the left in the lab, the clinical group, only some of the clinical group on the right hand. The important thing, as I mentioned earlier, is integrating clinical research with research in general, either biomedical engineering, imaging, or intracellular and other types of research. Thank you very much indeed.
Thank you very much, Professor Sir Magdi. This was an exciting lecture showing how the quest for the defeat of heart failure, one of the main scourges of our society today, is continuing through many collaborations, complex networks, and your last slide, the interaction between the older professors who hope to be and should be mentors and the younger generation who is our future. And thank you very much. I remind you, you can send questions to all of us, and it was a very inspiring talk. Let me continue, τα slides μου παρακαλώ, by showing that I have showed this already. I just want to stress that there is a common capital of knowledge and age in all generations. And we, as a committee of the European Association of Professors Emeriti, hope to promote awareness as regards the big problem of life expectancy and world health by many ways, statements, congresses, and by creating a think tank. Actually, this was words proposed by Sir Magdi when we started our efforts, and we aspire to increase the size of our think tank through collaborations, which is a main goal today, and to create opportunities for treating as many health conditions as possible. You will see our names. We are various disciplines. Up to now, we are mostly physicians and chemists, but we all strive to the same goal. Up to now, we are living in a world of excitement because you can see that life expectancy from 1900, from the beginning of the 18th century, has increased incredibly, has more than doubled. And the main causes for this wonderful effect have been increase of childhood and childbirth mortality, decrease of infections, so decreasing infections and childhood mortality has been a great boon. As a cardiologist, I remember that rheumatic fever, which was a main cause of disability and death, has practically vanished in the developed countries, and we aim at continuing this trend, or rather, we aimed. But there has been a worm among the roses. It has been a common problem that since 2015, this decrease in cardiovascular mortality, which you can see up to 2015, has begun to be offset due to increase of risk factors, aging, obesity, diabetes mellitus, and this has been even before the COVID-19 pandemic, which has added more than 5 million deaths up to now. Up to now, we were hoping that we shall reverse these predictions, these unfavorable predictions, up to 2040 by decreasing the risk factors, obesity, high cholesterol, hypertension, and also begin to bring in to our rescue innovations, technical innovations. And now we are faced with the duty to combat and defeat the surge of the COVID-19 pandemic. Because, as you can see in this rather busy but clear slide, some diseases are increasing. For example, up in red, coronary heart disease is increasing, pneumonia is increasing, dementia is increasing. There are many unfavorable increases, and depression is increasing, while other diseases, childhood mortality, stroke, diarrhea, infections in green are decreasing. So we want to continue this trend of hopefully stopping this threat which will occur 20 years from now. And you can see that life expectancy at birth has increased up to 2015, but up to 2020, it is, which we have now actually, it is seen that there will be a decrease in life expectancy, especially in the less favored, the less privileged populations. And this behooves all of us to try to stop this trend. This includes not only physicians, but people of statistics, finance, politicians, world leaders. And COVID is not just mortality, acute mortality. And here we must stress that being intubated does not mean that death is imminent. Intubation helps to prevent death, helps the person to regain his life, and with the newer drugs, apart from the vaccines, we hope to win the war and turn the tide. But you can see that COVID has long-term effects as well: cardiac, pulmonary, kidney, memory, sleep problems, fatigue, and quality of life. QOL decreases by 36%. So there is another war to be won. And many organizations are embarking on this effort. The improvement of the health of the public is a British effort, combining many disciplines and many populations, as you can see. And they all end up at 2040, like the Mayan calendar in a way. And Dame Anne Johnson, Dame, dear friends, is the equivalent in the United Kingdom of Sir, of knighthood. For women, it is Dame. So Dame Anne Johnson, again addressing health of the public 20 years from now, stresses big data, as Sir Magdi said, social media, citizen science, which is very important, involving all citizens in this effort, and many other sources. And it falls to clinicians and scientists of tomorrow and students, which is our hope, to ensure that many of these changes will be made. And the diseases of civilization, overnutrition, sedentary life, bring in diabetes mellitus, hypertension, cardiovascular disease, heart failure. Environmental pollution has been termed the tragedy of our horizon. Cancers, pulmonary disease, mental instability, strokes, sun storms, increased strokes, and of course social inequalities, poverty, refugees, migrants are beset by malnutrition, diarrhea, and increase again of childhood diseases. Again, 2040, another organization stresses pathways to the future, that healthcare is at the crossroads. We must involve technical solutions, technical progress. We must avoid to show that too much technical problem and not humanity, and not humanitarian efforts, and not the duties of the doctor for compassion, must avoid a backlash against technical achievements, which we're seeing now in the vaccines, where people refuse the vaccine. This is a technical backlash. We need to overcome this. And of course, don't forget that patients come first. We are the keepers of our patients. And improving, these are my two last slides, dear friends, the health of the public, rebalancing and enhancing coordination of research, harnessing new technologies, developing transdisciplinary research, aligning perspectives and approaches, collaborating with all sectors of society, global engagement. It's a grand challenge, but professionals from all disciplines should be involved in this effort. Physicians, psychologists, statisticians, economists, politicians, industry, and the arts and humanities as well. But also, and very importantly, and we want their input, the younger generation to whom we are living a wounded world. Please join us in this worthwhile effort. Thank you very much. The next speaker will be Professor George Christodoulou, a psychiatrist by trade, but a man of many wide interests. George.
Thank you, Dennis. Thank you for your excellent talk, and thank you, Professor Yacoub, for the same reason. I was impressed with this term, Alzheimer's of the heart, and this brought to my mind the Alzheimer's of emotions, which is schizophrenia, in fact, in my discipline. Dear friends, I was very much, very enthusiastic about the creation of this committee on prevention and health promotion, because this is very much in my heart, in my field of expertise, which is mental health. So it will be a great pleasure for me to speak to you about this very subject, health promotion, how to build health promotion. Right. So let's start from the beginning, and the beginning is the ancient Greek tradition. So the ancient Greeks worshipped primarily Υγεία, who is the goddess of preventive medicine, rather than Panacea, goddess of therapeutic medicine. The emphasis was on prevention, Υγεία. And this is exemplified in the Hippocratic Oath, where Υγεία is mentioned first, and then come the lesser gods and goddesses like Panacea. Before the 5th century, in ancient Greece, health was considered as a divine gift and illness as punishment. And it was the great physician Hippocrates who challenged this misconception with the sacred disease paradigm. As you know, the sacred disease was epilepsy, and it was thought up to the time of Hippocrates that epilepsy was the result of Zeus, who punished people with this. This was reversed by Hippocrates, who attributed epilepsy to natural causes, of course, to physical, pathological causes. And this created a tradition to look into this phenomena, originally attributed to the influence of gods, to physical causes. Health is perhaps an over-inclusive definition. It was originally associated with soundness of the body. Well-being was not included, but well-being was indeed included in the WHO definition in 1948. And this is in line with the broader perspective of the psychosocial school in medicine and psychiatry. This definition resisted time, and it is now 73 years from 1948 to now that has lasted time. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. The well-being concept was criticized by some, and the complete element was also criticized. The word complete makes it unlikely that anyone would be healthy for a reasonable period of time. And also, another criticism was that health, according to this definition, corresponds more to happiness than health. However, for us, mental health professionals, it is a definition which is very much to our liking. We like it very much because the definition is well balanced, it's inclusive, it is modern, and it is in line with the principles of person-centered medicine and positive health. Health promotion can be defined as action and advocacy to address the full range of determinants of health that can be modified positively. I should point out that in prevention, the key word is illness, but in promotion, the key word is health. Promotion is addressed to health, which is more important. The actions of health promotion are actions taken to promote health, which are the specific measures, and actions not taken for this purpose, but resulting in it, the general measures, which can be more effective than the specific measures. Specific measures then, and general measures. Which are the specific measures? Promotion of cessation of smoking, promotion of moderation in drinking, promotion of physical exercise, promotion of good nutrition, promotion of dental hygiene, promotion of safety in sports, promotion of prohibition of smoking in public places, about which Professor Becharek will speak later on, and screening for physical or mental disorders. You can see in this paradigm I'm using that 1 in 5 persons in the United States suffer from mental disorder. It's perhaps even more, and it's not valid also in the United States, but everywhere in the world. Vaccination is one of the specific measures, and of course this is very relevant to what's happening now with coronavirus. And also screening for breast, cervical, and colorectal screening. Which are the general measures? They are basically socio-political activities, like reduction of unemployment. As you probably know, unemployment is very closely linked with suicide, improvement of schooling, reduction of discrimination, reduction of poverty and inequalities. Poverty is associated with mental illness, as we all know, especially schizophrenia, and inequalities also play a major role. Other socio-political activities are management of financial crisis. As you probably know, financial crises are associated with depression, anxiety, stress, suicide. Protection of civil, economic, social, political, and cultural rights, reduction of stigma and discrimination. Peace is considered by the World Health Organization as a target of mental health promotion, and rightly so. In light with this, the Hellenic Psychiatric Association, the World Psychiatric Association, two task forces, have persuaded the Lebanese, the Israeli, and the Palestinian psychiatric associations to produce statements against the war. You may wonder whether this intervention has been successful. It has been successful with difficulty, especially with reference to the Lebanese Psychiatric Association. But of course, we did not expect the effect to be very decisive. We contributed to this in some way, and we're proud of it. And then we come to the 2016 Athens Anti-War Declaration, which was very important in my opinion. It was produced by the four associations that you can see here: the Society of Preventive Psychiatry, the Hellenic Psychiatric Association, the Psychiatric Association for Eastern Europe and the Balkans, and the Serbian Psychiatric Association, but was co-signed, as I said earlier, by more than 100 other associations worldwide. You can read what the content of this declaration is. I will not go into many details on this, but I will just point out that according to the WHO, mental health promotion should include efforts for peace in view of the well-established mental health consequences of war conflicts. So we established these 4 points: termination of war conflicts, psychological and material support to the victims of war conflicts, psychosocial and humanitarian material support to the citizens of the host countries, which I think is very important, and call for urgent and coordinated action to attain the above goals. As I said earlier, it was co-signed by more than 100 organizations and supported by the European Commission. Now we go on with the holistic health promotion. We all know, or we should know, that psyche and soma go hand in hand, as indicated in this wonderful statue by Antonio Canova. Holistic health promotion is sine qua non, because persons with physical illness have a greater risk to develop depression, and persons with depression are prone to develop cardiovascular illness, diabetes, cancer, and respiratory illness, therefore leading to 60% of premature deaths. So improving physical health helps mental health, and promotion and improving mental health promotes physical health. They go hand in hand. Which is the target population of health promotion? It is the whole population, and this is called universal promotion. But there are some priorities: children, old people, women, migrants, the LGBT group, lesbian, gay, bisexual, transsexual, disaster victims, persons with debts, and this is very relevant to suicide, persons with imbalances between responsibility and influence. What do I mean by that? I mean people who have to obey to strategies, who don't take part in decision-making, but have to implement decisions of others. it seems that this category of people is very prone to illness, and especially mental illness. Also, overworked people and persons prone to psychopathology, either on account of hereditary factors or on account of factors that are created during life. Evidence on effectiveness is a condition for investment in health projects, and continued availability of resources is also essential. And cost-benefit considerations should be communicated to decision makers. For example, the fact that provision of funds to mental health is cost-effective should be communicated to decision makers to be able to make intelligent decisions on this, and not limit mental health funding worldwide to just 2% of the general funding for health. In conclusion, and I will finish with this slide, I will read it. The aim of health promotion is to apply the person-centered, holistic, and dignity-promoting approach into strategies that will enhance the resilience of persons, especially those who are prone to developing physical or mental illness, by improving their well-being and quality of life on a personal and social level. So the key word here is resilience. Thank you very much for your attention.
Thank you very much, Professor Christodoulou. This was an exciting lecture. I want to stress what you said very pertinently. Physicians can bring peace. Don't forget that Bernard Lown, who invented the cardiac defibrillator in Boston and saved many lives by the cardiac defibrillator, also created, together with Soviet colleagues, a physicians' society for anti-nuclear effort, which by now has become a worldwide progress and has done a very important campaign. So physicians can be leading people in bringing about peace, progress in peace. Mm-hmm. And our next speaker, who will tell us how much does the problem of cardiovascular disease weigh in today's consideration, is Professor Guy de Backer from the University of Ghent, a well-known epidemiologist and old friend. Professor de Backer.
Thank you very much, Dennis. Good evening, everybody. And thank you for the invitation to join this association of professors emeriti, and to invite me also to join you tonight in this excellent meeting. And I don't know if I can have my slides already. The slide showing the title of my presentation. The title being the Epidemiology of Cardiovascular Diseases, from where do we come and where are we going? I think this is indeed a very interesting topic to see a little bit back, to look from where we come. And unfortunately, one of the advantages of the is that we can look back.
Place your own slides, Guy. Put on your own slides.
I will share screen. I will try to do that. I have to find them somewhere, but no.
Αν τα πάρετε εσείς, βάλτε τα εσείς.
There we go.
Okay, there you are.
You can see them?
Yes, absolutely.
So let me start with just summarizing with a few slides how I've seen the epidemiology and cardiovascular disease changing over the last decades. Of course, it is a very personal perception, and I can only give you a few illustrations. I can tell you that I have no interest to declare on the subject. Here you see that indeed epidemiological research into the cardiovascular disease, it started off somewhere very shortly after the Second World War, and one of the reasons for that was that they saw a very alarming, unexpected rise in CVD mortality in different industrialized countries in the world. Here you see that, for instance, the National Health Institute in the US observed that in 1987, that 44% of all deaths in the US were attributable to cardiovascular disease, and that was as compared to 1940, an increase of 20%. So at that moment, observational studies were set up in the late 40s in the US, and then a little bit later in Europe on the subject. And you can see all kind of studies, all kind of prospective studies that were set up in US and in Europe, including different ones also in our countries. And from these studies, a number of modifiable variables were identified by the end of the 50s as predictors of cardiovascular diseases, and you all know them: tobacco smoking, elevated blood pressure, elevated cholesterol, physical inactivity, diabetes, etc. So the concept of what we now call cardiovascular risk factors was very, very well established at that moment. Then the effects of changing these modifiable risk factors, for changing cholesterol, changing blood pressure, were studied in a few what we called unifactorial intervention trials. Now, the results of these trials were criticized and really did not convince a majority of our clinicians. So by the late 60s, the epidemic was still really growing and becoming really alarming, and the results of the intervention studies had divided the scientific society at that moment in what we call believers and non-believers. So it became also clear at that moment that really a web of causation was the basis of the pathology of cardiovascular diseases. Now, if the disease was multifactorial in origin, then it looked also plausible that its prevention needed a multifactorial approach. And this was the start of several trials to test a multifactorial intervention strategy at the level of the population and in high-risk subjects. And I recall you the WHO European Collaborative Group trial in the UK, Belgium, Poland, Italy, and Spain, the Mr. Fit trial, multiple risk factor intervention trial in the US, and then primary prevention trials in Göteborg and in Oslo. And from the results, for instance, of the WHO European Collaborative Trial, the late Jeffrey Rose, who was chairing that trial, concluded that in middle-aged men, the lifestyle changes that were advised were effective indeed in terms of CVD prevention, but to the extent that they were accepted and put into practice. And then somewhere in the 80s, we have seen the MONICA project contributing significantly to our understanding of the dynamics of the epidemic of cardiovascular diseases and also to the potential of its prevention. The main finding of the MONICA project was that about a third of the change in coronary mortality could be attributed to healthcare and 2/3 to changes in risk factors to prevention. Now, the multifactorial intervention trials were then complemented by what we are calling controlled trials at community levels, such as, for instance, the North Korea project in Finland and the Stanford Free Community Study in the US. Now, convinced of the effectiveness and of the safety of these intervention strategies, several demonstration projects were set up somewhere in the 90s, and you can see the examples of these in the slides, both in the US, but also in, for instance, Germany and in Ireland. And this brings us to the most recent period, where indeed results from Interheart and from the Pure study gave us a more global picture of the situation, and those from the EuroAspire surveys clearly demonstrating that the potential for primary and for secondary prevention is underused at this moment in most of our countries. And I just show you one example. For instance, here you can see results from the hospital arm of the 5th EuroAspire survey, which was conducted in 2017-2018. And on the left of the slide, you see the recommendations from the guidelines on prevention from DC from 2016, and on the right, the results of the survey. And as a matter of fact, in the white column, we should have 100% in all the rows. And you can appreciate how far we are still nowadays to that 100% for most of these recommended risk factor changes. So far a few snapshots from the past. Let me now speculate a little bit about the future of the epidemiology and the prevention of cardiovascular disease. So what we have seen in most of our countries is of course excellent. We can only hope that we can continue on that track. But we should also realize that prevention of CVD in the actual generation of adults is to a certain extent mainly a postponement of events rather than a complete prevention. So I think that in the future, we should indeed invest much more in what we are calling primordial prevention, really the prevention of the development of risk factors by age in most of our young people. And I remember what Jeffrey Rose once told me: if prevention of CVD works, it will result in an increase of the prevalence of CVD. And this is mainly due to the fact that indeed nowadays our populations are aging quite a lot, and that we have been successful in preventing premature deaths, but that unfortunately that we still have a lot of morbidity with effects on quality of life, etc. So all these requires continuous and really meticulous research, and it brings me already to one of the recommendations that I would like to put forward, and that has to do with really the question of continuous monitoring of health indicators, but not only just health indicators. There should be really very reliable, good quality health indicators. Good quality vital statistics are really essential to understand what is happening nowadays and in the future, not only regarding mortality, but also regarding morbidity. And that can be based indeed not only on good discharge forms, but also on community-based registers, as we have had in the MONICA project. Thus, are there at this moment still undiscovered risk factors that may be important for explaining the epidemic of cardiovascular disease? Well, one of the challenges that we are facing is how to identify and how to quantify possible indicators of what we are calling low-level exposure over a long time period on non-communicable diseases, such as cardiovascular disease. So the identification of novel markers may be important, even if they carry only a very small incremental risk on top of what we know already with the other risk factors. And again, this brings me to a message that Jeffrey told us in one of his excellent books here in the book on preventive medicine, telling us that a large number of people exposed to a small risk may generate many more cases than a small number exposed to high risk. Therefore, I think that risk factors that carry a very small risk may still be very important, and I'm thinking in particular at factors related, for instance, to our climate to noise, to all this kind of things. Another point that I would like to bring up is that in the past, epidemiology has used what was called by some risk factor epidemiology and by other black box epidemiology, where the human body is considered as a black box that could not be entered, and we measured what went in, and then we measured what came out, and we analyzed associations between measures without knowing exactly what happened in that box. And again, this has allowed epidemiologists to detect, I think, faster than in basic science, issues such as the relationship between tobacco smoking and lung cancer. But these are just examples. I think that in the future that we a little bit more in detail, and I am very in favor of an alternative approach of the black box epidemiology, an alternative that has been suggested by John Potter. And in this figure, you can see that with the discipline epidemiology, we can make a bridge between, on the one hand, biology, and on the other hand, prevention. From genetic markers to risk factors, markers of exposure, to the development of new methods, to descriptive and ecological studies, case control comparisons, observational cohort studies, randomized controlled trials, etc., come to really public health outcomes and public health policy. So I think this bridge indeed recognizes epidemiology as a basic science of prevention, but also as a sound and attractive means of translating scientific evidence in applications in medicine and in public health. So let's now try to summarize a few key steps that, in my view, again, may be important for epidemiology and prevention of CVD in the future. I think that there is indeed a continuous need for innovative research into the epidemiology of CVD. Observational studies for hypothesis testing need to be operated by well-considered a priori working hypotheses, not by data mining of large data sets without defined hypotheses. I think that we need to use measurement methods that are adapted to the research question. Many exposures are very dynamic, so observational studies that are restricted to just one snapshot of exposure have indeed numerous limitations. We need studies with multiple measurements, specific biosensors, and sensitive markers of chronic exposure. CVD are the results of complex interplay between multiple genetic variants and environmental factors. And I think that we need indeed more research to identify and understand the interaction between the genome and the environment. Genetic epidemiology may help in unraveling pathogenetic mechanisms, underlying biological elements, and in identifying novel targets for more personalized preventive strategy. Epidemiology is a team science. I cannot focus on that in enough detail. We should also avoid redundant and repetitive studies. It's a waste of time and of money. Given the existing knowledge on how to prevent CVD, there is a need for a major shift from etiological research into what I'm calling preventive research. We need creative preventive strategies that combine rigorous scientific methods with a meaningful impact on public health. And finally, we should respond quickly, I think, to new opportunities. There is a need for more epidemiological studies to evaluate the effects of societal changes on the CVD epidemic and to identify possible solutions. And I'm thinking in particular of effects of globalization, migration, socioeconomic changes, and unemployment. Tackling these causes of the causes is a pressing challenge at both the national and at the international level. So we have the evidence how to prevent that the epidemic that we have seen in the 50s and 60s in the industrialized countries, that these epidemics do not repeat themselves in other places of the world or persist in undeserved subgroups of our society. Further research is certainly needed, but we should also invest in the application of existing knowledge into public health and clinical practice. The potential for further gains in preventing CVD does exist. Let us implement this as good as possible. And I think that with this, I will thank you for your attention.
Thank you very much, Professor De Backer. This was a very comprehensive expose, a very comprehensive review. I stress two things that first of all the speakers up to now have spoken about teamwork, have spoken about innovation, biomarkers. So this is a common need for us to proceed and to progress. And you said something very interesting at your last slide, which actually Joseph Hill, the editor-in-chief of Circulation, wrote about 2 years ago, that we must try to avoid repetitive and time-consuming studies just for having publications. The pandemic has brought us a question of need, and need must be addressed by trimming unnecessary efforts if we want to move forward. Thank you very much. And our next and last speaker is Professor Panagiotis Bechrakis, a pulmonary specialist and intensivist, whom, apart from his participation, we really want to help to thank, because he gave us the means for this meeting through the Institute of Public Health of the American College of Greece, where we are emitting from. And dear friends, a bad technical result can ruin any effort. So if we have been successful up to now, this is in large part due to the contribution of our friend, Professor Panagiotis Bechrakis, who will speak about COVID-19 and smoking. A terrible combination, I would say. Panos.
Thank you, Mr. Chairman. Thank you, Dennis. Dear Mr. President of EAPE, dear Sir Magdi Yacoub, dear friends and colleagues. On behalf of the Institute of Public Health of the American College of Greece, we welcome all the participants to the first scientific meeting of the Committee on Prevention and Health Promotion of the European Association of Professors Emeriti. The event is supported by our institute in the purpose of discussing the role of prevention as an effective measure for the improvement of public health in Europe. And of course, it is a pleasure and honor for me to have the opportunity to talk about the relationship of COVID-19 pandemic with smoking, as smoking and COVID are the two major public health problems in global level. Starting with COVID-19, I am presenting the current status of the pandemic as it is shown, as it is described today by WHO. What we have in this map is that up to 24 hours before now, we have 261 million of cases, of confirmed cases of COVID-19 pandemic, including 5.2 million of deaths due to the disease. And another bad news is the issue of great concern the problem of the Omicron variant. It is a very new variant of the SARS-CoV-2 virus, which in a very short period of time has been spread in 4 continents. As it is shown in the map, the new variant started its deadly work in South Africa, but it has already moved to Europe, where countries like Spain, Italy, UK, Germany, and Sweden have confirmed the presence of Omicron variant. From America, the disease has been confirmed in Canada, and at the other end of the world, we have confirmed cases in Australia. The evolution of COVID-19 from the beginning of the pandemic until now is shown in these 2 slides, in these 2 graphs of WHO. In the upper panel, we can see the 4 waves of the confirmed cases, 261 and more millions, and in the lower panel, we have the 5.2 deaths. Just looking at these 2 figures, one cannot be optimistic at all about the near future and the further evolution of this phenomenon, which is still going on, and it seems that we have difficulties to stop it. I cannot change it. Can you? Can you give me the next slide, please? Okay. The distribution of these cases in the 6 regional areas of WHO is shown in this figure. The orange color depicts the cases of the Americas. The light green refers to the European region. The dark blue to the Southeastern Asia. The green to the Mediterranean Eastern region of WHO. The pink to the Western Pacific, and light blue to the Africa region. You can see that it is a rather uniform waveform of the evolution of the pandemic, and the same is the case in the next slide in the mortality. And of course, a point which has to be, I have to make here is that the data collection in these areas of the world is not uniform, so comparisons between the different regions cannot be very reliable. But just looking at the areas of Europe and the Americas, where we have reasons to believe that data have been properly collected, the evolution of the pandemic is going on. Next slide, please. Here we have the comparison of COVID-19 with smoking in global level. And we can see that the cases of COVID-19 are 261 million, but smoking is 1 billion per year. The deaths are 5.2 million in 1.5 years, the deaths are 8 million per year in smoking. Talking about management and treatment in COVID-19, it is only now that we can have a special medication. But for smoking cessation, we have available methodology and the drugs for smoking control. Talking about prevention, the specific vaccines against the COVID-19 do exist, and of course, specific educational programs also exist for smoking prevention. But we can see here that from an epidemiological point of view, smoking is much more dangerous for human beings compared to COVID-19. And of course, this is reflected in the statement of WHO, according to which smoking is the greatest epidemic of all times. And of course, it is a disease. It is not just a habit, as it commonly said. Next slide, please. Coming to the point, what is the relationship between smoking and spread of SARS-CoV-2? It is very simple to say that use of tobacco and novel tobacco products increases the hand-to-mouth contact by 200 times daily. It also increases the hand contacts with potentially infectious objects, like cigarette packets, lighters, ashtrays, vaping devices, etc. Use of tobacco and novel tobacco products make the use of face mask problematic. It is impossible to smoke wearing a mask. It also impairs the respiratory system defense mechanisms, leading to frequent bronchial and lung infections. Influenza and common cold viruses are known to be much more higher in smokers than in non-smokers. Tobacco use increases the environmental particulate pollution, which enable COVID-19's lingering in the air and enable distance traveling of the virus. If an infected person coughs in this room, droplets can be spread up to 8 meters from the point of the cough production. Next slide. It is an established knowledge today that SARS-CoV-2 virus adheres to the specific angiotensin converting enzyme receptors, ACE2 receptors of the respiratory system. These receptors are hyperregulated in smokers, facilitating the virus entrance in the lung. And SARS-CoV-2 easily overcomes the impaired respiratory defense mechanisms of smokers. This is the very simple concept of how SARS-CoV-2 prefers smokers than non-smokers. And the next slide, please. Increased SARS-CoV-2 spreading from asymptomatic and prosymptomatic smokers has also been proved due to the chronic cough and expectoration, to the environmental pollution by cigarette butts, ashtrays, passive smoking, and to the frequent smoking at home due to quarantine, to remote work, and leading to increased passive exposure of non-smokers and children. Next. In spite of all these very simple points I have already developed, with the onset of COVID-19 pandemic, a series of papers came up in an extremely fast way, trying to convince the scientific community, but most they convinced the journalists, which they reproduced it, trying to convince that nicotine and other nicotine-cholinergic agonists may protect the acetylcholinergic receptor system and thus have therapeutic value in COVID-19 patients. Another work suggests that pharmaceutical nicotine should be considered as a potential treatment option in COVID-19. Another paper refers to pharmaceutical nicotine or other nicotinic cholinergic agonists should be explored as potentially therapeutic options based on the recently presented hypothesis. And the hypothesis was that nicotine may have a protective effect in COVID-19. Another paper states that nicotine administration should be added on top of antiviral or other therapeutic options for COVID, saying to the patient that smoke to be cured. And the last one of my collection says that our findings provide further support to the hypothesis about the protective role of nicotine and other cholinergic agonists. Can we go one back? But the end of the myth came with the withdrawal of a paper. Sorry, the previous one. No. The next one. This is the one. The end of the myth came when one of these series of papers was withdrawn after its publication in the European Respiratory Journal. Later on, a series of very high-level publications came up. You can see journals like Circulation, Thorax, Nature, Journal of Medical Virology, and a series of very big names killed the myth of smoking as a protecting mechanism for COVID-19, and they clearly shown that. This is one of them. From the University of Oxford, based on 400,021 and more patients, with 1,649 COVID-19 confirmed infections, 961 COVID-19 hospitalizations, and 444 COVID-19 deaths, it was clearly shown that ex-smokers had the possibility 1.4 times higher to be hospitalized compared to never smokers, and current smokers had 2.2 times higher possibility to be hospitalized compared to never smokers. About mortality, the ex-smokers had the possibility to die if they were infected by the disease 1.8 times higher than non-smokers, and current smokers had the possibility higher 5.9 to die because of the disease. And another very important paper is coming from Munich, University of Munich, referring to also a very big number of patients, and clearly showed that tobacco consumption is a very high risk factor for complications if a subject is infected by the disease. And you can see in the right, not this, the next slide, please. I have it, sorry. This is the table I would like to present. Tobacco consumption compared to coronary disease is a little bit less, but it comes just after coronary disease as a risk factor for dying from COVID-19. In conclusion, I have to tell you that COVID-19 is a major public health problem, with Omicron variant being a worrying threat. COVID-19 cases and deaths are fewer compared to the smoking epidemic, and tobacco products use is a factor increasing the spread of COVID-19 from infected smokers to the community. The susceptibility of smokers to COVID-19, the clinical severity of COVID-19, and the chance of poor outcome. Thank you for your attention. And
thank you very much, Professor Bechrakis. Let's hope that at least the pandemic and its increased deaths at least may help in reducing smoking, and one more effort towards that. Dear friends, it has been 1 hour and a half as we predicted. We have had up to 146 participants, and we are very thankful to them. We shall not leave them alone. We shall write to all of them. We want their participation more actively. Professor De Santo, we hope that the APE will have more people coming after this seminar, and we count on your help. We have had some quite favorable remarks and a question, and then we'll have a few questions ourselves. A question for Sir Magdi by Professor George Nikolopoulos, who is in a physical education professor in the University of Athens. What do you think, Sir Magdi, about the athletic heart, the heart of the athlete? Is it a cardiological problem? Is it protective, or can it go to the other end of being harmful if one exercises too much?
This is a very interesting question indeed, because it is shown, for example, that regular physical exercise is a preventive factor for cardiovascular disease, and actually can reverse some of the harmful effects of HFpEF, heart failure with preserved ejection fraction, and hypertrophy. Thus, we've been thinking a lot about that. The hypertrophy seen in the athletic heart is different from the hypertrophy in diseases like hypertrophic cardiomyopathy, for example, which can cause sudden death. So the term reverse remodeling and pathological remodeling and physiological remodeling be increase in the volume of the heart and the cardiomyocytes is an area of active research even as we speak. What I'm trying to say is that there is physiologic hypertrophy versus pathologic hypertrophy. So the athlete heart, it is not as simple as all that. And one of the most important points is that sudden exposure to unusual effort in athletes as well, it can cause plaque rupture in the coronaries, and it can cause sudden cardiac death in a proportion of patients with different diseases like hypertrophic cardiomyopathy or anomalous origin of one of the coronary arteries. So the evidence is mixed, and we should differentiate between regular exercise in moderation and severe exercise suddenly. Have I answered the question?
Do you prescribe exercise to your heart transplant and LVAD patients?
Absolutely.
Absolutely.
I think
yes.
There was, we cooperated with one of the biggest rehabilitation centers in Canada, Terry Kavanagh, in actually rehabilitating our transplant patients, for example. And to the extent they couldn't walk 200 meters, and following rehabilitation and regular exercise, 3 of them ran the Boston Marathon. Then that's fantastic, because with the improvement in heart function. And as I said, I definitely prescribe regular exercise because it's the only form of treatment in HFpEF, the heart failure associated with normal ejection fraction, which actually is now almost half of the entire heart failure population, but we do not have very strong drugs for treating HFpEF, while we have for HFrEF. And exercise is one of two actually effective treatments for the treatment of half the heart failure population who have HFpEF.
Thank you very much, Sir Magdi. Professor De Santo, before I ask the other panelists, can we ask for your experience on the problem of kidney disease of today? I believe it is an increasing problem. Do you have some comments on that, please?
We cannot hear you.
Right.
Voice.
Έχετε φωνή, παιδιά? Open your microphone, please.
Okay.
Okay.
Kidney failure is becoming really important nowadays. And it is calculated that 3% of the net budgets of health budget is used for kidney disease. And the number, because every year it increases, and we are far from the equilibrium point. There is a lot to do on prevention. There is to do a lot on prevention, as generally we do. But the problem is, first of all, to be able to take care of the hypertensive patients. The second thing we could do, and we always try to instill to our patients from the very beginning, is to reduce the salt intake to a minimum, to the minimum possible amount, that is around 3 grams a day. It's a difficult goal to achieve. The other problem is to take care of the individual patients from the very beginning. Having worked with the nutrition in kidney disease, I think that there is a place for low Mediterranean diet, to have low protein diets. Low protein in the mean that 40 grams a day of proteins take it out the accelerator on the kidney. These are the things we can do. Less salt, less proteins, taking care of blood pressure. This would make a lot. But as Sir Magdi Yacoub said, this is not enough. Many patients die, and the best solution is, and the most economical solution, is to have a transplant. But this is difficult to achieve, and this is the goal that everywhere is pursued. And but there are less possibility to have a transplant nowadays. And you know that the living transplantation, that is a great possibility, is not so exploited, because we could do this a lot more, but it is not usually utilized as it could be. These are the simple things we can take care of the glomerular disease and also of the interstitial disease from the very beginning and follow them. These are the means that we can do. Thank you for asking me.
Thank you very much, Professor De Santo. We have 4 more questions, and we shall finish, dear friends. I want to ask Professor Christodoulou a question. We heard a lot about COVID. Has COVID affected mental health and mental stability? You have done some work in Greece in this theme. Can you give us a few words?
Of course, but before dealing with your question, Dennis, it's important to stress that depression that you have already mentioned is a great threat in the future in the way of epidemiology, because it's postulated that depression will be the major problem in the coming years. And this is expected, and you can see it happening. So with reference to your question, just to bring the discussion into focus, we have indeed done some research from the Society of Preventive Psychiatry, and we have found out that depression, anxiety, and stress have increased during the COVID era. And also obsessions and compulsions related to the COVID-19. What is interesting is that the age groups that have been influenced were the older people, pensioners, people living alone, people divorced or separated. And in general, the quality of life, as measured by the WHO instrument, has deteriorated during this period of the COVID infection, and the measures taken of distancing, which were very important in the way of creating major mental health problems. The common factor that joins these groups that are more vulnerable is, I believe, loneliness. Older people, pensioners, living alone, divorced, separated. These were the more vulnerable people. And I think it's important to look into this issue of loneliness in the future. Thank you for your question.
Thank you very much. Professor De Backer, you gave a very detailed account of the threats and of the hopes which epidemiology is studying today. Have we really seen any improvement in obesity and in domestic, rather sedentary way of living, despite all our efforts, and especially from your group and from your work in the European Cardiology Society. Have we any programs on that, or we need other work to do?
No, I must admit that really the improvements that we have seen in the 70s, 80s, in my country, for instance, when I started with some surveys, early 70s, 70% of our male population was smoking. 70%. At this moment, we are now at 20%. So we have had a tremendous and fortunately a very good, in some countries, a very, very good decline in smoking, although nowadays we are still facing 20-25% is still 20-25% too much. And then also in terms of, I think, nutrition, major changes have taken place in many communities related to, I think a greater variety in our nutrition and our dietary habits have occurred, fortunately, because we nowadays much more food available, different foods available. And also I think hypertension control has indeed been a little bit better, although even nowadays we still have problems with that. But then unfortunately, as you said, the epidemic of obesity and of overweight and obesity really as what started also somewhere in the 70s, 80s, and nowadays it's still increasing in many countries. There we have in Europe enormous differences when we look in Euroaspire at the prevalences of overweight and obesity, and certainly of central obesity, between north, south, east, west. These differences are enormous. And this has to do certainly with differences in physical activity levels that have decreased over the years. So indeed, if we have to invest in the future, and I think WHO and other institutes are investing in improving preventive cardiology in the future, then I think overweight, obesity, and physical activity are not the new targets, but are really the targets that are now maybe on top of everything else.
Thank you very much. First, before proceeding with the last two questions, I must mention that an esteemed group of our working group of our committee is Professor Luigi Campanella from the University of Sapienza in Rome. He could not be with us tonight, but we are all working together for the next efforts we shall be doing as a committee. Two last questions. Sir Magdi, Dr. Tassos Hadjis is asking, heart transplant from animals to humans, an old dream. Is there anything new? I remember that Dr. Hardy in Mississippi doing a transplant of a chimpanzee to a man, which did not succeed. The heart was too small. Is there any progress, any future on that with transgenic animals?
Again, this is an excellent question, because xenotransplantation or transplantation for animals have been under a very heavy cloud, and many of us were totally against it. In what way? The most important two factors which were preventing xenotransplantation, particularly from pigs, primates are out, of course, was one, hyperacute rejection, which is quite different to rejection. The mechanism is different, but a lot of research on that. And the fact that there are preformed antibodies in the human which hyperacutes rejection, the pig heart. But one of the most important things which was really occupying all our minds, or most of our mind, is the so-called PERV. What is PERV? PERV is pig integrated enterovirus, PERV. And PERV was one of the main factors, because all the pigs have up to 28% of their genome integrated PAV. Now, everybody said in the very early days, oh, it doesn't matter because it will not form a variant and it will not transform, be able to live on a human, and therefore it is not a risk to humans. Actually, a virologist in London, next to our own institution, proved that this is not true. He grew PAV and put it on a human kidney, and it grew. Not only that, it produced variants, and the variants started to attack other tissues. So this was a risk of not only like having a lot of mortality or wiping out the human race completely. Now, several committees, I will finish soon, I'm sorry, were examined the risk of wiping out the human race due to PAV. And there was one in the US and one in Europe. Both of them came to the same conclusion, that the risk of wiping out humanity, this is a dreadful thing, of course, is rare, but it is definitely more than zero. Both of them agreed that there was a risk, even if it was small. Professor of epidemiology will understand that very well. And quoting Jeffrey Rose, if you have a common thing, even if it's a tiny risk, it's a disaster. Now, I have to say, in ending my talk, is the last few years have seen massive progress in getting rid of the gene which has causes hyperacute rejection, and importantly also neutralizing PAV, and therefore there has been quite a lot of progress in xenotransplantation research, which used to be said, xenotransplantation is around the corner and will always remain around the corner. I think it is a bit more now. It is approaching reality. Now, when this will happen, is it 5, it is 10 years, but progress in xenotransplantation, like what you have said, Professor Kokkinos, and through transgenic animal, manipulating the human genome. Initially, it was by different methods, but now we have gene editing by CRISPR-Cas. That has already been used to tissue engineer or have xenotransplantation, or eventually tissue engineer hearts. Thank you for the question.
Thank you very much for giving us the vista, the road lying ahead of us for exciting new discoveries. This is just the beginning, I believe. You know, dear friends, that medical knowledge doubles every 12 months. So in 2 years from now, we shall give you 4 times more knowledge, hopefully. And the last question, again dealing with transplantation, is for Professor Bechrakis. Lung transplant to COVID patients. I guess long-term if they have too much damage. Again, by Dr. Tassos Hadjis. Professor Bechrakis.
I don't think that there is any experience on this, and probably the question should be addressed to the cardiologists here, not to me as a pulmonologist. Probably myocarditis due to the infection.
But lung transplant, Lung transplant.
Sorry.
Yes, lung.
COVID in lung transplant.
Yes, for example, too much destroyed lung. Will there rise a view for lung transplant?
I haven't heard of any case now. It is the first time that I face such a kind of question. I haven't seen anything in the international literature regarding transplantation, lung transplantation due to COVID. Of course, extracorporeal membrane oxygenation has been widely used in difficult cases, and everybody knows about the artificial ventilation in the ICUs. I am sorry, but my knowledge does not go further.
Is the last question, because comes from that, getting intubated, does it mean death? Or is it a reliable way of saving a patient's life? Because, you know, many people have the impression that you must not be intubated because being intubated, you will die. Can you give us a good account for that?
Having spent many decades of my life in ICUs, I have to support exactly the opposite.
Exactly.
I have seen cases of patients who were considered lost to survive. So I think that the use of ICU today is a very strong measure of saving lives and should not anyway be considered as the opposite. I don't want to go further because the question here is about the refusal of some patients to have this kind of treatment, which is a difficult question. We plan to discuss about this in the next meeting of our institution on the 15th of December.
You can send us an information to join you there, if we can. All these people participating tonight could join, perhaps.
Yes, it will be on the 15th of December, and we have invited very great names of Greek scientific world, and we shall try to answer this kind of questions, one being the intubation. If I have to answer today, my personal opinion is that we don't have the right to intubate a patient if he does not want to be intubated, as far as he is non-mentally ill, and he has been clearly informed about the situation, and he has the ability to approve or not the suggested treatment. If he does not approve it, we don't have the right to do it without his will. This is my approach to the problem.
We shall discuss this during your meeting.
Yes,
Send us an invitation. And dear friends, this is the matter that we want to express. We all want collaboration. We are thankful for you for being with us tonight, to all the help from all the associations meeting with us and sending us their views. We hope to have in the next few months another meeting, and we need you all. We shall contact you all, especially the younger people. We want to have them with us. They are our future. We, as mentors, will try to continue our efforts, but with all of you together. Thank you very much for the meeting. Good night. Thank you very much.